Hi, my name's Kirsty, and I'm a biomedical scientist in histology. During the COVID-19 lockdown, I had some spare time on my hands, so I thought I'd have a look at the technological future in histology. Histology being how tissues and organs work inside the body. But before we have a look at the future, I thought we'd have a quick look at the past. So where have we come from? Well, back in the 1600s, there was a scientist in Italy called Marcello Malpighi, and he looked at the respiration of the silkworm in embryology. Notably, even today, many structures within the human body are still named after Malpighi, such as the Malpighian corpuscles and the Malpighian layer in the skin. Late in the 1700s, tissue was actually recognised by Xavier Bichat, who was a French anatomist and physiologist whose systemic study of human tissues helped found the science of histology. He recognised that a tissue within an organ may be impaired without the entire organ failing. He worked mostly by dissecting corpses, though he was steadfast in refusing to use a microscope, as he thought that the tool's imperfections up to that point made it no better than chemical tests in the naked eye. In 1830, J.J. Lister fixed the microscope issues and presented the new improved version in 1830, which led to the Germans fully establishing the field of pathological medicine in the 1850s. In the 1850s, also permanent mounting became available using Canada balsam, and tissue fixation also started to happen. And the first recognised stain was carmine in 1770. So continuing with our theme of where we've come from, I love this picture because it really does show how labs used to be and all those special stains bottles that used to be there. Back in 1863, Mr. Wilhelm von Weder gave us hematoxylin, which is obviously a mainstay of histology still today. 1875, we got the gram stain. 1883, the ZN. 1891, the Gemsa. And in 1891 also was methylene blue. And the methylene blue used to be used to treat malaria. In the late 1800s, paraffin wax and formalin fixation also came on the scene. So the microtome also became available around this time. So this is the 1830s. The most common microtome is the rotary microtome, and this is about all you see in New Zealand. Also available are the sliding and the sledge. I've worked with a sledge microtome in the UK. I believe this is a Cambridge rocker, which I've only seen in a museum. And again, this is a freezing microtome, a bench freezing by the looks of it. And that is a freezing microtome that could be attached to a bench. Mainly these days we would use a cryostat, which is a rotary microtome inside of a freezer cabinet. So the next big jump in technology in histology would have been in the 1980s. So what's that, 150 years later? And that was immunohistochemistry. So if we have a look here, I think we basically all understand this at this stage. It's been around for a while, but this is about identifying an antigen on a cell, then attaching an antibody to that antigen to make a complex, and then attaching a labeling system to that antibody that makes the antigen then visible down the light microscope. Another example is immunofluorescence. So again, we've identified an antigen. A primary antibody has been used to identify it, and that antibody has a fluorescent tag attached to it. So then that antigen can be identified down a fluorescence microscope. Immunohistochemistry has been revolutionary for histology, and in this day and age it is absolutely being valued in the area of immune therapy, where the drug that a patient is treated with is directly related to the diagnostic tests using immunohistochemistry. Examples are Herceptin for HER2 and cetuximab for EGFR. They really are being great at doing targeted therapy to give patients the best outcome. So where are we headed? Well, this picture might look quite futuristic, but I'm not so sure. The technologies that are available out there really are changing how we look at what we're doing. In fact, some of the technologies I've looked at completely obliterate histology as we know it today. And I found investigating this talk really, really exciting. So let's take a look. So I thought we'd start with the digital pathology. And as hard as it is to believe, it's already been around for 20 years. The earliest virtual microscope was developed in 1996 to 1998. This is a high-tech computer system, for example the Omnics Precision solution, which is able to read samples of human tissue and aid pathologists in the identification of minute changes in cells that can indicate cancer is present. The first digital microscope systems cost about $300,000 to set up and took over 24 hours to scan a single slide. These devices have advanced significantly over the past 20 years. Today, whole slide scanners are capable of automatically producing very high-resolution images that replicate glass slides, so-called virtual microscopy, paving the way for using WSI for primary diagnosis. All of this information is going to be stored in the cloud. So currently, pharma and biotech companies have the largest share in the global digital pathology market. However, it is expected by 2026 that Asia Pacific region will be showing clinical as the largest growth market. Terms like whole slide imaging, WSI, and vendor-neutral archives, VNA, are just terms that are going to be rolling off our tongues. And the FDA already have 2 approved commercially available scanners. So an extension to digital pathology would be 3D imaging. So this is where the construction of 3D models from 2D images happens. So this can be done to construct an entire organ or even an organism. There is challenges, however, and that's to do with the histological processes. And these process challenges are answered with algorithms. Now I'm not going to go into all of that because that's beyond my pay grade. But you can see with this video what's going on, and this is looking at renal tissue, and we're going to have a look at a glomeruli. So stacking slices together is akin to putting a cake back together after slicing it up. So that might be okay for 5-year-olds at a party, but surgeons wanting to know about surgical margins, not so much. Sectioning stretches, bends and tears the tissue. Staining is variable, and fixation causes tissue destruction. This has mainly been done on human embryos for the Kyoto collection of human embryos and fetuses. It's been done very successfully, however they don't have MRI or CT scans to reference their material against for what they've been doing. Now personally I'm not overly keen on this method, mainly because it would be a massive increase of work for the histotech, because as you can imagine you would have to be serial sectioning a lot to get this information done. So continuing with our digital imaging extensions, we now take a look at artificial intelligence. So artificial intelligence can use algorithms to check the diagnosis rendered by the pathologist. It's all about starting to use these digital images for building helper tools for the pathologists as a decision support workflow. These images can be analysed using machine learning, deep learning and artificial intelligence tools to look for mitotic figures, bacteria and even grade cancer. Using the power of the cloud, it is possible to create a pixel pipeline-based workflow which allows for creating AI-based prognostic and diagnostic algorithms. A study in 2011 successfully demonstrated an image-based risk score can be generated by training the computer to detect the prognostic features, only using a digital image and without the need to perform expensive molecular assays that can take days to perform. More recently, deep learning systems have been designed to help pathologists differentiate between benign and malignant prostate tumours. Google has actually developed an artificial intelligence that can search the web for morphologically similar features, regardless of annotation status, their system is called Smiley. It's a similar image search for histopathology. If we have a look at these pictures, so this is a pathologist annotation on particular slides. And this is the deep learning model that is happening with the artificial intelligence. So moving on from digital pathology, we're now going to take a look at something called liquid biopsies. So this is blood-based cancer biomarkers, which is a promising non-invasive alternative to tissue biopsy. So the abnormal and uncontrolled cell growth, known as cancer, is considered the second leading cause of death globally. A liquid biopsy is the analysis of biomarkers in a non-solid biological tissue, mainly blood, which has remarkable advantages over the traditional biopsy. It has no risk, it is non-invasive and painless. It does not require surgery and reduces the cost and diagnosis time. The most studied cancer non-invasive biomarkers are circulating tumour cells, CTCs, circulating tumour DNA, which is ctDNA, and exosomes. These circulating biomarkers play a key role in the understanding of metastasis and tumorigenesis, which could provide a better insight into the evolution of the tumour dynamics during treatment and disease progression. So let's take a look at the advantages of liquid biopsy. So obviously when you compare with a normal biopsy in radiology and MRI, a blood test is really simple. And also you don't need to access hard to get tumours, such as in the brain or around major vessels, and patients with major comorbidities are simpler as well. The temporal and spatial heterogeneity of the tumour, so that is several populations of cancerous cells, with different genetic variations might exist in different regions of the tumour, or have considerable differences between the original lesion and a recurrence. The concentration of these biomarkers in the bloodstream may contribute to an earlier detection of a stage of cancer and a more favourable prediction of the prognosis in patients. So this picture is just a selection of different ways that this technique could be done. I'm not going to go into these because they're really not my area of expertise, but feel free to have a look at them further online if you would like to. So what does this mean for us today? Well, it's really an emerging technology, but it's an emerging technology with vast potential. So in order to broaden the understanding of the cancer metastasis and its molecular landscape, a real-time tracking of the development of the tumour dynamics is required. For this reason, liquid biopsy-based approaches provide a valuable tool for minimally invasive diagnosis and monitoring. However, there are still some concerns that need to be answered. Are the ctDNA sequences a clear clue about the stage of the cancer? Is the information given by the sequences present in the ctDNAs the same as the ones inside the exosomes and the CTCs? Considering that ctDNAs come from dead cells, in contrast to the DNA existing within the exosomes, which will try to colonize new body regions, or the one inside CTCs that is escaping from the primary tumour. What variability of information could be extracted from these different sources to help in the prognosis and the patient treatment? Again, I can see the potential here. Now this picture is again just an example of how this works. So you've got the normal and tumour cells are going into the blood is collected, and then it's put into something like this, which is an EV isolation centre chip. And then I'm not going to get into the details of how that works because that's a little bit past my level, but you can see the things that are going on out there that could really be helpful. So now for the technology that I find really exciting. So this is MUSE, which is microscopy with ultraviolet surface excitation for rapid slide-free histology. I just think this stuff is super cool. But anyway, so this is a simple, non-destructive, slide-free technique that within minutes provides high-resolution diagnostic histological images resembling those obtained from conventional hematoxylin and eosin histology. The approach, named MUSE, can also generate shape and colour contrast information. MUSE relies on 280 nanometer ultraviolet light to restrict the excitation of conventional fluorescent stains to tissue surfaces and it has no significant effects on downstream molecular assays, including fluorescence in situ hybridization and RNA sequencing. MUSE promises to improve the speed and efficiency of patient care in both state-of-the-art and low-resource settings, and to provide opportunities for rapid histology in research. MUSE images can resemble those from standard histology slides and bright field microscopes, while also providing surface and colour contrast features not usually present in standard H&Es. The approach relies on two phenomena. First, ultraviolet excitation light, particularly at wavelengths shorter than 300 nanometers, which penetrates the tissue just a few microns deep. That is, the approximate thickness of a typical histology slide. Second, this excitation light can elicit bright emission from tissue specimens stained with conventional fluorescent dyes. Despite being excited in the relatively deep UV, these stains emit photons in the visible range. The visible band signals can then be captured using simple to operate and inexpensive conventional glass-based microscope optics and either grayscale or color cameras. Fortunately, some of the dyes with this favorable excitation emission behavior have proved to label tissue components with specificities resembling the H&E. So now we're going to take a quick look at the principles of MUSE, which is surface-weighted excitation and long-Stokes shift fluorescence emission. So if we have a look at diagram A, it's a schematic diagram of the MUSE optical design. So we're using an inverted microscope design, which has been modified to include a UV transparent stage and off-axis UV LED illumination. So here, if we have a look at the picture of B, this is unfixed ovine kidney, which is cut surface has been prepared by razor blade. It's been stained with eosin and imaged using a grayscale camera excited with 405 nanometers. C is the same, but we've used 280 nanometers sources. So you can see that the tubules and the collecting ducts are easier to discern with the 280 nanometer UV because of its surface limited tissue penetration. Now I'm just going to skip over D because that's a graph and I'm not too into that. So if we pop along to E, this image is captured from the cut surface of a thick formalin fixed porcine kidney, which was stained for 10 seconds with a mixed solution of rhodamine and Hurst and excited using a 280 nanometer UV LED. Multiple colours are visible, showing the muscular arteries internal and external laminae in orange. Here, collagen is blue, the nuclei are lilac, and the tubules are orange and green. So the endothelial cell nuclei extending down inside the artery are also visible. If we have a look at that over here, because F is a magnification of just that part there. So we know what steps formalin fixed paraffin embedded processing consists of. So what about MUSE? MUSE processing is minimal. It involves tissue orientation and possible surface preparation via manual cutting, using a sharp blade, staining the tissue for as little as 10 seconds, rinsing for 20 seconds, and placement directly onto a UV transparent stage. Here you can see the left column fluorescence MUSE images from the cut surfaces of formalin fixed tissues. So these ones here. So these were briefly stained with Hurst rhodamine and eosin and propydium iodide and captured with a colour camera and white balanced. The middle column is the same images which have been converted to virtual H&E. So these are exactly the same. And the right column is digital images captured using a whole slide scanner from conventional H&E stain slides on the same specimens after paraffin embedding and sectioning. So you can see here, these are what we're used to looking at as far as H&Es go. So taking a further look at the additional shape and colour information that can be gained from MUSE, we have a look here at specimen picture A, which is the standard formalin fixed paraffin embedded histology of a human kidney with proteinaceous casts filling some tubules. If we have a look at B, the same kidney is imaged with MUSE and is pseudo-coloured for clarity. Casts can be seen as cylindrical structures, including one that was dislodged from its original site. C is an H&E image of a schwannoma. The swirling nature of this tumour can be appreciated. And in picture D is a MUSE image of the same specimen, in which the three-dimensional organisation of the tumour can be appreciated. I just find this technology really quite amazing. So we have a look at E. This is a seromucinous ovarian carcinoma shown by H&E. The carcinoma-lined tufts surrounding fibrovascular cores are visible. And if you have a look at F, it's the same tumour imaged with MUSE, revealing cauliflower floret-like clumps of malignant epithelial cells outside of fibrovascular cores. A window into a core is visible at the top right. If we have a look at G, this is a conventional FFPE, and then H. So this is a MUSE image from a similar region. So the chief, the brown, and the parietal cells, orange, are much easier to distinguish in the MUSE fluorescence image. We have a look at I. We've got a fixed porcine renal tissue, which has been imaged by H&E, and J is the corresponding region by MUSE fluorescence. So the stromal features, some are identified by number, are easier to distinguish in the MUSE image. So you can see the stromal features really clearly. So it's like we're looking at seeing the convergence of advances in microscopy, digital image processing and machine learning, which could eliminate most of the tissue handling steps and enable rapid diagnostic histopathology of entire biopsy tissue in the laboratory. It would also enable large sections of fresh tissue to be assessed in the operating room with unprecedented resolution and with contrast and diagnostic accuracy rivaling that of expert pathologists. So in summary, the preliminary validation of MUSE has been done, although more studies are needed. Molecular analysis is looking promising, and MUSE doesn't appear to interfere with any of those tests. We've got an extended field of view or whole slide imaging. It's promising suitability to replace frozen sections, although formal assessment of this is still needed and in progress. It's giving 2.5-dimensional surface profiling and extended colour gamut. And this is giving us the ability to appreciate the 3-dimensional surface profile information and also tissue preservation for further investigation. So moving on, you can do other things. On the other hand, some useful artefacts from formalin fixed paraffin embedded tissues are being lost, such as the chromatin clearing of some tumours. And this gives a picture that resembles FNA in frozen sections. Searching for small metastases in lymph nodes could be a challenge, although it's suggested that a vibrating microtome could be used and slicing the tissue at 50 microns or less to find those. UV penetration is slightly deeper, and this can give nuclear crowding. An interpretation of a different picture would take an adjustment in those using it, so for the pathologist they'd need to get used to looking at different information. So again, I thought we'd have a wee look at some pictures I have in the middle here. So A is lung with clusters of histiocytes encased in a fine membrane. Apparently these are not visible on the corresponding H&E, which apparently I haven't actually included, but there you go. B, this is ovary stroma with germinal epithelium. C, we've got skin. This is with epidermis, dermis, skin appendages. The collagen is green, elastin is yellow, and the dermal epidermal melanin is visible. And this is a Hurston rhodamine eosin PI stain. D, this is spleen with a prominent blood vessel. E is myocardium with a thin layer of endocardium covering part of the specimen. around here. F, this is a cool picture. This is fresh breast tissue with a nerve coursing over and through the layer of intact adipocytes. It's pretty amazing. G, we've got normal colon on the left next to adenocarcinoma on the right. H, this is the pineal gland with pineal sand visible. And J, this is also a cool picture, is a sebaceous gland in the cervix. All of these have been stained with rhodamine and HIST as well. So while all of this is very cool, I really wanted to finish my talk today on something that's actually available at the moment. I originally did this talk for my colleagues in New Zealand, but I know that some of you may be watching this from overseas, so you may well already be using these, so please ignore if that is the case. So I just wanted to talk about the biochip. It's pretty cool, I like it. We do a lot of prostate biopsies and breast cores and things where I work. So this is a chip that would be used in theatre for them to put their core biopsy straight into. This would preserve and protect the core biopsy so that they didn't break apart. Using this chip, we can use, it's got arrows, you can use the top and bottom. The cores are labelled. There's also little measurements on it, so you could put like core 1, 2, 3, 4, 5 and 6 through here. And then all of those core biopsies could be sectioned in the same block. This is it in the core biopsy going in at theatre, and this is a section. So it's a protein gel matrix which is easily sectioned. Comes in different gauge needle sizes, so 18, 16, 14 and 12. So it's a cost-effective way of actually getting a better result for the patient. I like these. So we might get to use them, who knows. Thank you for taking the time to listen to this talk. Hope you enjoyed that slide transition. As I may have mentioned, I did this talk during COVID-19 and my children decided to help me out with some of the slide transitions. That was definitely one of them. Any questions? Please feel free to write them down. I'm not sure if I might be able to answer them or not. Other than that, looking forward to the future in histology. Thanks again.